Good afternoon, and welcome to this session about optimization of clinical management with novel or established treatments. And we were very happy. We have 2 invited speakers, and then we have 4 selected abstracts. And this is my co-chair, André Ng. How can you pronounce your name?
Yes, André Ng. I'm a clinical academic from the University of Leicester. I'm president of the British Cardiovascular Society. And thank you, Janine.
Yes. Yeah, my name is Janine Rutus van Lennep, and we're very happy to be the chairs for this afternoon.
Good. Well, without further ado, we'll get started. Can we invite all speakers to stick to time, please? The invited speakers will have 15 minutes for presentation, 5 minutes for Q&A. And after that, our abstract speakers will have 8 minutes for presentation, 2 minutes for Q&A. So I'm going to introduce our first speaker. It's my great pleasure to introduce Dr. Evangelos Okonomou, who is a cardiovascular medicine fellow at Yale University and postdoctoral fellow in Yale Cardiovascular Data Science Lab. He's an associate editor for the European Heart Journal, and his title of the talk is on integrating multidisciplinary data for advanced phenomapping of risk factors. Evangelos.
Thank you so much for the kind introduction, and thank you so much to the organizers for the invitation. It is a pleasure to be here with you and present some of our ongoing work in the Yale Cardiovascular Data Science Lab on how we can integrate multimodal data for the advanced phenomapping of risk factors. And just a disclaimer, some of the work that I'll be presenting might be more applied to cardiomyopathy, but there's definitely a lot of the work that we've been doing that we're also applying to atherosclerosis, coronary artery disease. But what I'll be mostly focusing on is the methodology and how we can think about risk factors using multimodality approaches. These are my disclosures. So what are we going to be talking about today? We're going to be talking about digital biomarkers, how we think about those in our lab and how we've been approaching their development and validation, how we can train and develop multimodal approaches for multimodality systems to better phenotype risk factors and cardiovascular disease. And then at the end, we'll try to put everything together and talk a bit about how we can better flag and identify individualized treatment effects using such multimodal approaches. Now, let's start with digital biomarkers, and there's definitely a lot of heterogeneity in terms of how people define that. But let me just give you a simple example. Let's take the example of CHA2DS2-VASc, a risk score that we use very frequently in our everyday clinical practice. Let's take H, for example, hypertension. How do we define that? We assign a simple 0 or 1, sort of dichotomizing a risk factor that has substantial heterogeneity in terms of its phenotypes, mostly because that's way simpler to deploy at the bedside. But then there's a lot of things that we don't account for. Is there evidence of hypertensive heart disease? What's the degree of LV remodeling? What does that patient's ECG look like? Is there LVH by ECG criteria? Is there macrovascular disease, and so forth? And obviously, every patient will have a different phenotype and will fall on different ends of the spectrum. And there is a lot of different combinations. And how do we quantify those in a way that is interpretable and therefore clinically actionable? A challenge with digital data is that there's a lot of data that we acquire every day. So if we take the average echocardiogram that was done in our hospital in the last year, the average size of that is approximately 0.5 gigabyte of data. There's a lot of images that we acquire, a lot of videos, obviously, as part of a standard transthoracic protocol. But when we actually report it, we end up with a 100-word summary. That's actually 0.2 kilobytes of data. That's a compression of almost 2 million times in terms of the data we acquire and the data we report. Obviously, there's a reason for that. If we break down the amount of information and the data that we acquire, a lot of it is noise, artifacts, random variation, clinically insignificant data. What we actually end up reporting is the visible labels that we think are important. However, there's also a layer of information above that, which are the hidden labels, labels that have diagnostic and prognostic value, but we do not routinely report or include in our reporting. And this highlights 2 ways in which AI, ML, and digital biomarkers can help us. The first one, it can automate what we are already doing, so make things faster, but more importantly, it can also augment. It can do things that we would not normally do and we would not normally see. There's a lot of examples out there. I'm just going to highlight 3 key examples of how we can do that across modalities, starting with electrocardiography. I know Rohan just presented a lot of that earlier today, but just to give you an example of how we can use the ECG and the ECG image per se as a biomarker. So, and we know that there's a lot of diagnostic and prognostic information there. But a lot of work in our lab has shown that we can actually get quantitative biomarkers, diagnostic and prognostic, directly from an image, a screenshot of an ECG, a photo of an ECG. We can detect different forms of structural heart disease, and more importantly, we can actually prognosticate the patient's trajectory based on the ECG. And in many cases, that's a far better and stronger predictor of downstream events than BNP or routine risk stratification scores that we use. Moving on to echocardiography, point-of-care ultrasound imaging, a lot of the work we've been doing is on developing digital biomarkers of disease-specific biomarkers from echocardiography videos. So this is work that we've done in the aortic stenosis space, and what we've shown is that it's obviously easy for a human eye to recognize aortic stenosis from a parasternal long axis. In most cases, we don't necessarily need Doppler, but we do need Doppler, obviously, to appropriately grade the severity and confirm the presence of aortic stenosis. But for screening purposes, moderate to severe aortic stenosis we can detect visually. So we've trained a biomarker to do exactly that. We call it a digital aortic stenosis severity index. It can be easily applied to point-of-care ultrasound scans that people can acquire a single video of a parasternal long axis to screen for aortic stenosis. But where this becomes important is that if this becomes an objective, reproducible biomarker, no matter who acquires the image, it will always provide the same number. And this becomes really important when we stratify risk with patients that do not have severe aortic stenosis. So if we stratify patients that were reported based on their echo report as having no AS or just sclerosis but no hemodynamically significant stenosis, we can see that this biomarker alone is able to stratify the patients who are more likely to progress faster and return a few years down the line requiring aortic valve replacement or presenting with heart failure. And another example, which I think is a great example, is coronary CT angiography and characterizing perivascular adipose tissue phenotypes to better understand coronary inflammation and residual atherosclerotic cardiovascular disease risk. The work done by Professor Antoniadis' lab in Oxford, and where we've shown along the years that there's a lot of information that we acquire, but we hadn't been looking at, and we can actually link that to radiomic and transcriptomic profiles to better understand residual inflammatory risk that was hiding there, but we were not recognizing. And in fact, that can really redefine how we think about coronary disease, moving beyond the coronary cross-sectional coronary stenosis paradigm to a more biologically meaningful paradigm that integrates inflammation and the core causes and drivers of atherosclerosis. Now, obviously, this is not how we practice clinical medicine. Clinical medicine is inherently multimodal. So we never really look at just one modality. We look at the patient as a whole. We look at their EHR. We look at their notes. We look at the history. We integrate labs. We integrate ECGs. We integrate images. And eventually, I think we are already seeing this transition towards multimodal systems. In fact, I will cite an example from our ongoing work, which is in amyloid cardiomyopathy, but I think it's very elegant and really demonstrates how we can use multimodality approaches, and a lot of those principles actually translate across different domains. So, in fact, we know that if we suspect a given cardiomyopathy, we'll have an echocardiogram, we'll have an ECG, we'll have additional information in most cases, and we'll integrate all that information to really improve our pretest likelihood of a condition being present. In fact, we've been training models when we really care about diagnosing amyloid cardiomyopathy. We've trained models in the EHR, we've trained models for the ECGs, we've trained models for echocardiograms, and we know that these models can actually identify people who are progressing even before they actually get referred for testing. So the x-axis here is time. The green line, our patients went on to get diagnosed with amyloid cardiomyopathy. Yellow line is age and sex matched controls. And what you see here is that there's an evolution in the phenotype that we flag by actually just measuring the quantitative output of that model from a simple ECG image or a simple echo report of those patients over many years. And sometimes we can actually discriminate someone is likely to develop amyloid or be diagnosed with amyloid cardiomyopathy up to 3 years before they get diagnosed. But obviously, if we want to screen at scale, that might actually translate into a lot of false positives, a lot of unnecessary testing, a lot of unnecessary anxiety. And therefore, we think that a very good approach is to actually integrate all that information that like we normally do when we interpret clinical data, and actually identifying people who screen positives across multiple different modalities, because these are the people who are much more likely to have the true phenotype if they have an electrocardiographic signature, an echocardiographic signature, maybe an MRI signature, and so forth, an EHR signature that is strongly suggestive of the phenotype. And in fact, when we do that across multiple hospitals and across a multi-center study, the TRACE-AI effort that we're currently leading in the United States, we see that these are the people that are much more likely to have worse outcomes if they screen positive across multiple modalities, much more likely to be diagnosed with a condition later, and we're also testing this paradigm prospectively right now in a prospective study. Now, moving on from single risk factors to a more global assessment of risk. And what do I mean by that? So this is work that we've been doing in using randomized clinical trials. And these are clinical trials that are openly accessible because we want our findings to be reproducible, and we also want to contrast it with what other people have done. So what we've done in our lab is we've developed a method that allows us to create a computational phenomap of a clinical trial. So what you see here is 3 key examples. The first one is SPRINT, you know it, intensive versus standard blood pressure control. PROMISE, a study evaluating a functional versus an anatomical testing strategy in suspected coronary disease. CANVAS, one of the earlier studies studying canagliflozin in patients with diabetes, looking at MACE. And what you see here, every dot is a patient, and this is a mathematical construct, the visualization of that actually incorporates those patients' demographics, their labs, their medications, their imaging data, their ECG data, and actually creates like the phenomap of that study. And as you can see, the 2 colors for each study are the treatment arm that the patients got assigned to, and obviously this was done at random, and therefore it's randomly distributed in that space. But obviously, not every patient in that trial is the same. So if we focus on a given patient, we know that there's patients that were more similar to that index patient that were included in the study, and other patients that were very much dissimilar. And therefore, we can do mathematical modeling to actually optimize and to provide a more personalized interpretation of the average treatment effect that the study provided, but from the unique point of view of that patient. So for a given patient neighborhood, for example, we might see that the treatment is associated with significant efficacy, no safety concerns. There might be other patient profiles and neighborhoods where there's not as much of a signal of efficacy, and other neighborhoods where there might be even harm. And actually, when we can do that for every single patient, and we can do that at scale, and that way we move from those phenomaps to risk phenomaps that actually reflect the heterogeneity of the effectiveness of an intervention as a function of a patient's baseline multimodal profile. So left, you can see SPRINT. Most patients did have, in most patients, the intervention was superior to the control. In PROMISE, there's much more equivocal findings. In CANVAS, most patients benefited from canagliflozin, but there were certain phenotypes where maybe the effect was less pronounced. We always make models that are parsimonious and easy to access. We always publish our models on our lab's website for other people to experiment with. But where does this lead us? And I just would like to highlight a couple of different thoughts that we've had over the years to show how phenomapping can also advance other patterns of clinical investigation and discovery. So one way to do that is we've been thinking that would be a great way to maybe improve in some cases or change how we think about clinical trials. Not always, but in some cases. So we know that clinical trials, by definition, enroll a non-randomly selected sample of the general population. So we identify patients who have a given condition that we care about, let's say patients with high cardiovascular risk, and then the trial would test an intervention versus a control in that sample. But we know that not everyone responds the same way necessarily. And what if we had a way to actually dynamically, as a trial is running, as we transition from a phase 2 to a phase 3 trial, learn from the ongoing data to actually optimize and the targeted profile of the patients where we think this intervention might have the greatest net benefit, and therefore make the trials safer, more efficient, and less costly. We've actually simulated that across many studies. One example is the IRIS trial, published more than 10 years ago at this point, but essentially this study ran over 5-6 years studying pioglitazone in patients who had insulin resistance and stroke or a prior TIA. And we see, if you see the blue dots, the blue bars, if we implement our phenomapping strategy at each interim time point and we adjust how the trial enrolls its patients, we simulate that this trial could have actually had almost 15 to 20% reduction in its size without affecting the final effect size. And obviously, this does not affect randomization because this purely models baseline data, and still randomization is preserved because a given patient will still have 50-50 chance of getting randomized to treatment or control. And finally, I would like to highlight some work from Ariam Noraya, one of the amazing postdocs in our lab, who has actually implemented this concept of phenomapping in the UK Biobank to see whether there's a phenomapping multimodal signature that can identify patients who have an elevated risk of or elevated Lp(a), because we know, unfortunately, in our health system and across many health systems, this is rarely measured at scale, even though hopefully this will evolve and change as awareness about Lp(a) grows. What he's shown is that it's actually realistic and feasible to screen for elevated Lp(a) at scale using phenomapping strategies. In fact, if we use a phenomapping guided approach, we can reduce the number needed to test to identify a single patient with elevated Lp(a), but by up to 60%. And in fact, we can map that to our cohorts in the US and across our Yale University health system and see that people who screen positive by this phenomapping strategy have an 87% higher risk of elevated Lp(a). So in summary, digital biomarkers are disease-specific diagnostic, predictive, and prognostic risk scores derived from routine unstructured data. Multimodal phenotyping boosts the precision of AI systems by leveraging the complementary nature of cardiovascular diagnostics. And ultimately, we feel that an integrated, data-driven approach to this phenotypic heterogeneity may inform the optimal allocation of diagnostics and therapeutics across clinical trials and the real world. With that, I would like to thank everyone in our lab. It takes a village to do this work, and I'm happy to answer any questions you might have. Thank you.
Thank you very much. Wonderful talk. Can I just remind the audience that you can field questions through the mobile app? Whilst you're all thinking, can I just ask one question? Obviously, this is wonderful work, and this phenomapping is a very promising technique, and obviously it needs a lot of data, a lot of good quality data. How much of the data and approach that you're doing is actually segregated by sex and ethnicity, and also in international trials, the behavior which may not be congruous in different countries?
Excellent question. As is the case with any modeling strategy, your models are as good as the data that you train them on. And that becomes very important, especially for training, because you can deploy in a more diverse cohort, but if you have trained in a very homogeneous cohort with not as much diversity by many demographic and clinical factors, then you might not necessarily build a model that will generalize and pick up and make sure that it's equitable and performs equally well for different demographics. So in our case, we're privileged that we work in an environment that has substantial demographic diversity. So the models that we trained locally in our system, we've seen them generalize across the nation in the US and even internationally without any significant drops in performance. When it comes to clinical trials, we're obviously limited by who the clinical trial enrolled. And ultimately, we do always incorporate sex and key demographics into our models, whether ultimately those should become part of the deployment, especially as it relates to race, because this is more of a social construct than an actual. So that's a different story. But we always explore this performance to make sure that it's equal across protected demographic groups. But we're always limited by the trial that we're modeling.
Thank you.
I think that even more highlights the importance of enrolling a diverse population in clinical trials. And of course, in the case of women, we know that there's still a lot to do. So maybe it's also good that you can point out that aspect because, well, the models don't work if you only have 15 or 10% women in the trials.
Correct.
Are there any other questions from the audience? Oh. If not, then thank you very much.
Thank you so much.
Exciting work. Then we go to our second presentation, using advanced phenotyping tools to enrich clinical trials. Is it time for companion diagnostic by Professor Jan Nielsen? And I looked it all up. Professor Jan Nielsen is professor in the Lund University in Sweden, but also in App Centra, USA.
Thank you. So I will talk about the importance of having specific new accompanying technologies to image or detect an effect if you develop completely new therapies. These are my disclosures. So you know a lot about residual risk by now. And we've been talking over the years about the residual cholesterol risk because we haven't gotten LDL cholesterol levels down sufficiently. But we are now getting better and better at treating high cholesterol levels. And there is no evidence that the most important risk in subjects that are receiving guideline therapy is not the residual cholesterol risk, but the residual inflammatory risk. And the way we have to measure that is CRP. And you can see here a number of trials where they reach the goal for LDL cholesterol lowering and still have HS-CRP above 2 milligrams per deciliter. And there's quite a substantial number of patients that has that. Now, the residual risk we have is not generally inflammation, but specifically vascular inflammation. And CRP doesn't really measure that. CRP measures systemic inflammation. So if we have new therapies that target vascular inflammation, we need something better. So what can we do to develop assays that measures arterial inflammation and plaque inflammation better? And this has been very difficult over the years. There are some imaging technologies that can show plaque structure, and also some radiolabel techniques where you can measure uptake of different tracers into the plaque. But they are difficult. They usually use radiation, and there are specificity issues. Now, some years ago, Professor Antoniadis and his co-workers at the University of Oxford came up with a brilliant idea. We shouldn't look on the artery wall itself. We should look on the fat that surrounds it. And this is a remarkably good idea, I would say. So if you look on the normal artery, it is surrounded by fat cells. These fat cells contain fat, and they have a fairly uniform size. And they have a specific attenuation if you look on a CCTA image. However, if there is inflammation starting to occur in the vessel, there will be cytokines diffusing from the intima through the media into the surrounding adipose tissue. And these cytokines will activate these adipocytes. And as a result, they will start to release lipids, they will become smaller, and there will be more water in the tissue. And this will result in attenuation changes that you can score based on the CCTA. And you can see the changes here. So in the markedly inflamed artery, most of the yellow, which is then obtained through this 5-score technology, is disappeared and is red or even blue, which is the marked changes of the fat cells. And you're already seeing one version of this diagram. It's from the orphan study. Before you could, in the previous presentation, you see increased phi score in different numbers of vessels. Here is the quartiles, and you can see that there is a tremendously high increase from the baseline lowest quartile to the highest quartile, an almost 7 times increased risk. And the really interesting thing was that the increased risk was similar in those with obstructive coronary disease as with those without obstructive coronary disease. So we're measuring something that is perhaps more important than the size of the plaque, the inflammation of the plaques. So, can this technique be used to evaluate plaque-specific therapy, especially anti-inflammatory plaque-specific therapy? So, what's the key player in this? It's the macrophage in the plaque. They play a critical role in regulating inflammation. They're not the only cells, by far. Endothelial cells, smooth muscle cells also are active when it comes to inflammatory responses, but the macrophage is more important. One thing that macrophages in plaque does is to take up cholesterol from oxidized LDL, forming the foam cells. We originally thought that this was the real culprit. But it now turns out, when we're doing single-cell RNA sequencing from human plaques, that the foam cells have a protective role. They are anti-inflammatory. But if they are driven by an overexposure to oxidized LDL and inflammatory signals, they turn into cells that are on the verge of dying and become pro-inflammatory. So then they become the inflammatory culprit. Activating macrophages also secrete matrix metalloproteinases that are involved in the destabilization of the plaque by degrading collagen and elastin. They secrete the cytokines that activate the inflammation in the plaque. And inflammation also oxidizes LDL, which then comes into a vicious cycle. And eventually, if you have lipid overload in macrophages, they will die and release a lot of pro-inflammatory material. So what about oxidized LDL? I'm sure that many of you have seen thousands of figures with oxidized LDL, but although that we have very strong experimental evidence that oxidized LDL or LDL oxidation is a key factor in both the initiation of plaque development, in plaque growth, and also in plaque destabilization, it's been very difficult to transform this into a clinical therapy. But what oxidized LDL does, or rather the oxidation is, you first have the normal native LDL in the circulation. In the circulation, you may also have minimally modified LDL, and that's LDL which have oxidation of phospholipids on the surface. And Chris Binder talked about those particles earlier today. Then in the tissue, you can also find the more fully oxidized molecules. But both the minimally modified and the fully oxidized have the same pro-inflammatory effects. And they act on the endothelium, which become dysfunctional, expressing adhesion molecules. They attract leukocytes that come in. Monocytes become tissue-resident macrophages, which secrete cytokines, and you see a development of foam cells. They will also indirectly stimulate smooth muscle migration into the plaques, and that's more by effects on the macrophages. But oxidized LDL may also kill the smooth muscle cells by overloading, and that's important because that can destabilize the plaque. And there is a lot of oxidized LDL in plaques. In the circulation, oxidized LDL is cleared effectively in the liver. However, in tissue, there is an accumulation. It's removed by the macrophages, but there is still a lot of LDL there, oxidized LDL, which cannot be removed and stay in the tissues. So what about if you treat with statins? Can you remove that? You can lower the LDL cholesterol levels, but you can only get rid of part of the oxidized LDL that continues to be present in plaques in spite of lowering LDL cholesterol. There are natural defenses against this. One defense line is represented by antibodies. There are two types of antibodies. It's the IgM, a natural type of antibodies that react with oxidized phospholipids on oxidized LDL, but also on apoptotic cells and other debris. And their function is mostly a household function. They clean up debris. once you have a more severe oxidation that affects ApoB, you're also generating an IgG response, and that detects MDA modifications in ApoB. And to study this effect of such, we have developed a recombinant human antibody, which we call oticumab. So what happens here is, in the plaque, there are multiple mechanisms that activates inflammation through macrophages. It's cytokines, there's oxidized LDL, there's LPS, but there's also impaired efferocytosis of dying cells and so. So a lot of different things contributes to plaque inflammation. So what this antibody oticumab does is not blocking the effect of oxidized LDL or neutralizing or helping to clear it away like the IgM. What it does is to form an immune complex with oxidized LDL, which then binds to the inhibitory Fc receptor 2, and that shuts off inflammation in the macrophage. So it doesn't only inhibit the inflammatory effects of oxidized LDL, it inhibits the inflammation caused by all types of factors. Does it affect atherosclerosis? These are studies we did a long time ago in hypochloremic mice. They have been given cholesterol-enriched food for up to 25 weeks of age, then transferred to low cholesterol food, which would then mimic the clinical situation of being on statin treatment. That induces a minor regression of atherosclerosis, but if you add oticumab, you get a highly significant reduction of both the macrophage content and the total plaque area in these mice. So it's always good to have an effect in mice, but does it work in humans? So it's been in 4 studies now. The first 2 are just safety studies. Glacier, as some of you may have heard of, was a trial with oticumab in stable cardiovascular disease patients. It proved safety, but no efficacy, and there's been a lot of discussion why there was no efficacy, and the most likely explanation is that there was too little inflammation to treat. So I'm going to talk about a 4th study which was carried out in psoriasis patients. Why psoriasis? Well, psoriasis patients have an autoimmune activation. It affects the coronary, so you have a more aggressive coronary disease development, which is driven by inflammation. And we randomized 77 people with twice as many to oticumab. We have 40 in the active group that completed the study, 20 in the placebo group. The effect was assessed by looking on CCTA at baseline and after 16 weeks. And we had paired scans for 32 in the active group and 19 in the placebo group. And based on the experience from the Glacier trial, we also made a sub-study on those with high inflammation, high 5, from baseline and compared them with low inflammation at baseline. And here are the results from the high inflammation group. There was a reduction of coronary inflammation as assessed by the PHI score, both in the right coronary artery and in the circumflex, and there was a borderline reduction in the LAD. And you can transfer this data into a risk score. This only takes into account the severity of the coronary disease, of the plaques, and also clinical risk factors. And what we saw, if we did this, was that there was almost a 50% risk reduction. And the Cardiac risk score measures the risk of MACE within 8 years, while there was no such effect in the placebo group. So, summing up, in this, I would say, very small pilot study. We have to keep that in mind, and there were also some limitations to come to the balance between the 2 groups, but there was no increase of affection, which we have seen with the systemic anti-inflammatory treatments. There were no drug-related adverse events, no changes in chemistry or ECG, and no changes in lipid profile. So there were limitations with the study, but there were also some very promising results that are in line with previous experimental study. So what we need to do is to confirm this in a larger study, and this study is just about to start, possibly within this month. It's called Fortify. Here is the NCT number for clinicaltrials.gov. And in this, we will go back to the cardiovascular population. So these are post-MI patients. And we will screen with CCTA and FI score to identify individuals that have increased remaining coronary inflammation in spite of guideline therapy, and to see if we can reduce coronary inflammation by treatment with otilimab in this population. Thank you, and these are my acknowledgements.
Thank you very much. And if somebody has a question, please come up to the microphone. We have one question online, and that's a question, can we use IL-6 as a marker of inflammation?
If you're talking on arterial inflammation, IL-6 is a better marker than CRP, but it's still a systemic marker, so it measures the inflammation in all organs of the body. So it's better than CRP, but it's not a specific marker for plaque inflammation or vascular inflammation.
Yeah, and mindful that this is a small study, as you mentioned, in the psoriasis patients. Is there a reason for the smaller effect in the LED compared to Certiflex and right coronary artery?
There are some other small studies using FI score in psoriasis, actually, with different antibody-based treatments. And there has been the same experience that the effect is smaller in LAD than the others.
Is there a biological reason why? Is it a regional issue, or?
I think either Harris could answer that, or I think it still remains to have an explanation to that.
Stefano?
There's a microphone at the back, I think. Yeah.
Thank you. Great talk. So wouldn't there be reason to do that in other autoimmune diseases? Because apparently all the autoimmune diseases have high risk, so not only psoriasis. So I'm just saying it would be easier to find patients, but yeah. What do you think about other autoimmune diseases?
No, I think that's a very good point to see. And there are a number of autoimmune diseases that are associated with increased vascular risk, which is evidently inflammatory mediated. So it makes great sense.
Good. Thank you very much. If there's no further questions, thank you for a great talk. So next we have the abstract presentations. We have 5. Again, just remind the presenters to stick to time, 8-minute presentation, 2 minutes for Q&A. The next speaker I'd like to introduce is Chenbo Zhu. She is a resident physician in the Department of Cardiology at the First Affiliated Hospital of Xi'an Jiaotong University and visiting scholar at Emory University, USA. And the presentation is entitled AAV Gene Therapy for Homozygous Familial Hypercholesterolemia from Bench to Clinic.
Thank you for the introduction. Good afternoon, everyone. It's a great pleasure for me to be here today, share our recent work entitled AAV Gene Therapy for Homozygous FH from Bench to Clinic. I have nothing to disclose. As you are all well aware that FH is a rare autosomal disease characterized by severely elevated ASCVD, elevated LDL cholesterol level, which lead to accelerated ASCVD and early death. The clinical features including ensomatosis, premature atherosclerosis, and aortic valve disease. And HoFH is caused by mutations in genes involved in clearance of LDL particles, mainly including LDL receptor, PCSK9, and ApoB. Among these, LDL receptor mutations accounts for over 80 to 90% of the cases. So in this case, LDL cholesterol does not bind to mutated LDL receptor and lead to accumulation of LDL cholesterol in circulation. So based on the key role of this LDL receptor in the pathogenesis of HoFH, we conducted this study to see if we restore hepatic LDL receptor expression through AAV-mediated gene transfer could reduce the plasma LDL cholesterol level. And let me now walk you through the main findings of our study. So first, recombinant AAV serotype 8 containing a human LDL receptor gene sequence were designed and optimized to reduce the immunogenicity and enhance the liver-specific expression. And among the 17 AAV LDLR we designed, the one who exhibits the highest protein expression of LDL receptor and the lipid uptake ability was selected for the study. And then we treat LDL receptor knockout mice with the AAVH LDLR. And as shown, you can see here, the treatment demonstrated a remarkable decrease of the LDL cholesterol level in a dose-dependent manner for up to 36 weeks. And similar, the atherosclerotic plaques were also reduced, particularly in this high-dose group. And because the golden hamsters has a lipoprotein profiles that are more similar to those of humans, we also tested this treatment in golden hamsters. In LDL receptor knockout hamsters, the similar results were found where this treatment exhibits a visible clearer serum as compared to control. So the results so far supported the initiation of translational study. So moving forward, we tested the safety and toxicity of the vector in the rhesus monkeys. Due to time constraints, I will not discuss this in detail, but the results confirm that AAV vector is safe and well tolerated in non-human primates. And we then ran open-label, non-randomized study aimed to evaluate the safety, the tolerability, and also the efficacy of a single intravenous infusion of the AAV in HoFH patients. So the key inclusion criteria is the male or female aged between 12 to 55 years and diagnosed as HoFH with the LDL receptor mutations. And the primary endpoints including safety and LDL cholesterol levels, LDL cholesterol reduction over 52 weeks. And we are very excited to introduce our data we have so far. So these are the baseline characteristics of the first 3 patients we have enrolled so far. So all of them has densematosis and coronary heart disease in a relatively young age, and they received intensive lipid-lowering therapy, including statin, ezetimibe, and PCSK9 inhibitors, but still, the baseline LDL cholesterol level is extremely high. And we adopted the dose escalation rationale to reduce the patient exposed to ineffective dose. Basically, it's if one patient, the LDL reduction does not reach over 20% by week 6, we will consider to increase or double the dose to the next level. And here shows the results. The x-axis represents the weeks post-injection. And as you can see, this LDL cholesterol level, the low-dose patient, as shown in purple, does not fail to achieve a sufficient LDL cholesterol level by week 6. And by the end of 52 weeks, we can see there is a decrease of LDL cholesterol level, but we cannot conclude that if it's because of the treatment. So since this is not sufficient, we double the dose to patient 2, which received a medium dose. And as shown in blue here, the medium dose caused a modest decrease of LDL cholesterol levels, but with fluctuations ranging from 3% to 33%. So we increased the dose to patient 3, which to this high dose. And this high dose, the LDL cholesterol level starts to fall within 1 week of the treatment and fell below 1.5 millimolar, that is 55 mg per deciliter, since week 3 and remain at that level till week 32. And we also observed that Lp(a) was decreased by the treatment and nearly reduced to undetectable. And importantly, all of those 3 patients does not suffer severe adverse events. Because immunoresponse has long been a concern in gene transfer therapy, we also noticed that all of these 3 patients has elevation of liver enzyme, as shown here, but it was asymptomatic and controllable. We use the immunosuppressants to control the ALT and AST level. And I want to mention that for this high-dose patient, she has already stopped the use for statin and izimab and PCSK9 inhibitor because her LDL cholesterol level reached to a very low level. And after we stopped the use of this other lipid-lowering treatment, her LDL cholesterol level still remain at a very low level. So to conclude, treatment with this recombinant AAV8 LDLR was efficacious, especially the high dose is in HoFH patients, and also it was safe and well tolerated. So longer follow-up and additional studies are warranted to confirm our findings. And we want to thank all the participants and their families. And also, we have just been approved by FDA to initiate the phase 1 clinical trial in America. And so if you're interested in becoming a site, no matter it's in America or other countries, don't hesitate to contact us for more information. Thank you.
Thank you. Very exciting study. Can I just start off my question just so that we understand? So your first patient and the second patient, they stayed at a low and medium dose, but they didn't switch over to a high dose. Only the third patient had the high dose.
Yes, right.
Why?
Because this AAV injection, it could cause the immune response. So the patient will have the antibodies for that. So if we give them twice, the immune response will become very severe. So
Okay.
yeah.
Okay, and I think we've got a couple of questions online here on a similar vein about any potential problems, any non-target side effects. I think you've highlighted maybe there could be safety issues. You highlighted ALT rise. And how about other non-target sort of side effects or adverse events that we can be looking at? Is there any preclinical data to guide whether we know what to expect if there is going to be some danger?
So far, the 3 patients, the side effect that they experience is a fever and some like gastro reaction after the treatment, but we don't have any other data on other side effects. So far, it's mainly the problem we are concerning is liver enzyme, but it's still, the level is not that high and is under control. And for those patients, the corticosteroids were titrated off already, and they are also used the sirolimus to control this immune response.
It's very impressive, especially your patient 3. It seems it lasts forever. So is there any issue on durability and tolerance of gene therapy in this area?
Yes, so the durability is a question that we're also wondering because, this other gene transfer trials, like the studies on hemophilia, they have followed up patients for like 5 years, and they can found that the gene expression is going down as time goes by. But the difference between like hemophilias to our disease is that for hemophilias, they only need like 5 to 10% of the of the cells to express the protein that they can have the effect for the disease. But for this HoFH, we want the cells to express as more as LDL receptor as. So we still like following this patient, and we will see. Yeah.
One very brief question: how long did you also gave them cortisone before the injection? Before the treatment?
So during the treatment, when we infuse this to the patients, we'll use the corticosteroids through vein, and after that we will convert to oral. But we didn't use these drugs before the treatment.
And how long did you give the oral cortisone drugs?
The oral I have data here. Oh, okay. So for the first patient.
Well, if it's a problem, then I'll ask you after the session. Don't worry.
So it's let's see here. So for the first patient, it's after the ALT level dropped at 13 weeks, we gradually titrated off. And for the second patient, there is for the third patient, there is a second peak of ALT increasing. So after we titrate off the glucocorticoids, we add it like from around 15 and 16 weeks to control this second peak.
Well, really exciting work, and we hope to hear more about how your patients are doing and also about the new patients that will receive this treatment. Thank you very much.
Thank you.
Then we go to the next presentation about adherence to lipid-lowering medication in genetically familiar hypercholesterolemia and cardiovascular risk, a registry cohort study. And that will be presented by Ingrid Engre-Breedsen from the University of Oslo in Norway.
Thank you, and thank you for this opportunity to present our ongoing research with the real-world evidence on adherence to lipid-lowering drugs. These are my disclosures. Despite the availability and efficacy of lipid-lowering drugs, LDL-C target achievement remains suboptimal in both primary and secondary prevention of coronary heart disease. A prerequisite for treatment effect is that the physician prescribe the correct drug and dose, and that the patient use the medicine as prescribed. The aim of this study is to evaluate adherence to lipid-lowering drugs and the association between adherence and coronary heart disease in patients with familial hypercholesterolemia. This study is a registry cohort study including 3,000 patients with genetically confirmed familial hypercholesterolemia and approximately 22,000 controls without FH. Follow-up was through 2018. Information on patients were gathered from 5 nationwide registries with high coverage, and together they covered hospital contacts, pharmacy dispensed drugs, births, and causes of death. Adherence to statins was measured by the proportion of days covered, and the proportion of days covered was calculating by summing up the number of tablets dispensed from the time of the first statin dispensing until end of follow-up. And then we divided by the number of days in the study period. And now over to some, I forgot to say. And then the effect of adherence on coronary heart disease was evaluated by cumulative incidence and adjusted hazard ratios estimated by Cox regression. We allowed for a time-varying proportion of days covered, as adherence can vary over time. And now over to some results. During the initial year following the FH diagnosis, 70% of the patients collected at least one statin prescription, and 19% collected at least one ezetimibe prescription. The proportion with at least one prescription collection increased with years since diagnosis. And for ezetimibe, this was also because ezetimibe became more common in Norway during the study period. In total, 273 patients did not collect any statin prescription during follow-up. These patients had a mean age at diagnosis of 24 years, and 59% were female. During the study period, the mean proportion of days covered was 0.76, meaning that the patients collected enough statins to cover 76% of the days in the study period. 6% of the patients had low adherence, meaning that they had statins to cover less than 20% of the days in the study period. Further, 35% had medium adherence and 59% had high adherence. We found that poor adherence to statins was more common in females and in younger patients. Overall, 6% of the FH patients experienced a CHD event during follow-up. And this graph shows the cumulative incidence of coronary heart disease dependent on adherence level and for controls. So patients with no statin treatment are represented by the blue line in this graph. And as you can see, patients without statin treatment had higher cumulative incidence and hazard of coronary heart disease compared to patients with low, medium, or high adherence. Patients with low or medium adherence, which is represented by the green line, had higher incidence than patients with high adherence, represented by the red line, but this difference was not as profound. Regardless of adherence level, FH patients had higher risk of coronary heart disease compared to controls, which are represented by the purple line. When we adjust for age and sex in estimation of hazard ratios of coronary heart disease, we see the same pattern. Patients with low or medium adherence have 2 times higher hazard of coronary heart disease compared to those with high adherence. Importantly, patients with no statin treatment have 5 times higher hazard of coronary heart disease compared to those with high adherence. The main strength of this study lies in the nationwide registries with high coverage and the inclusion of a large population with genetically confirmed FH. In addition, we had access to information on pregnancies, which is rare in analysis of adherence, so we were able to control for that. There are some important limitations. First, we did not have any information on the reasons for suboptimal adherence. And second, we did not have any information on LDL levels in this study. To conclude, we see that in our population of familial hypercholesterolemia patients, high adherence to statin therapy was associated with a lower risk of coronary heart disease. Even low or medium adherence was associated with lower coronary heart disease risk compared to patients with no statin therapy. It is therefore vital to optimize statin adherence in FH patients. Yeah, this is the research team and the contact. Thank you.
A question from Stefano. And if there are other people who have a question, please come up to the microphone.
So do you think that the excess of mortality in the high adherence could be maybe because they were diagnosed later in life? I mean, the average diagnosis was 37, so that you can not catch up with the burden, or why do you think that's the case?
The high adherence was associated with
the
lower
excess in the risk that you see in the high adherence?
Yeah.
Is it due by the fact that they were diagnosed late in life and they didn't start soon enough?
Yeah, could be. We haven't investigated that, so we were not sure what we were going to see in the results with high adherence compared to controls without FH. The controls are not necessary on statins even. They are randomly drawn from the population, so it's maybe an unfair comparison, but mean age at diagnosis of 36 years is might be an explanation of high exposure to LDL.
Can I ask, your medium adherence is quite a big range, 20 to 80%. Have you got some granularity of where the majority of the patients are sitting? Are they all the bad ones, or are they leaning on the low, the 20s to 50s, or on the high end? What's the spread there?
Yeah, so what we saw when we performed the analysis of cumulative incidence, we had to merge the groups with below 20% and 20 to 80% because there were quite few patients in both groups. What is a difficulty in this registry data analysis is that in Norway, when you collect a prescription, you collect it for 3 months. So automatically, if you have one prescription in a year, you have a quarter of the year covered. So I don't remember if it was more patients in closer to 20% or 80%, but that's something you can look into if you have a longer follow-up.
Yeah. The most important thing, the most important finding in your data is actually to be applied to close the loop. And have you actually disseminated to the patients to tell them that they shouldn't be in the 20%, they should be in the high, beyond 80%? Have you done the dissemination to the participants of the trial?
No, so this is just a registry study, so there are no participants that are aware that they are included in this study. Okay. So that's for another intervention, maybe in the next study.
Thank you.
Well, thank you very much. And we have to go on to the next presentation by Professor Luis Massana. And he will talk about lomitapide in the pediatric patients with homozygous familial hypercholesterolemia and about analysis of the long-term safety and efficacy.
Okay, thank you very much for giving us the opportunity of talking about our data on lomitapide, the use of lomitapide in pediatric patients with homozygous familial hypercholesterolemia. I am talking on behalf of all the authors that you see in this authorship list. And this is my disclosure slide. I'm not going in front of this audience to talk or to spend time explaining what homozygous FH is, but just I would like to remind you that we are talking about a very nasty disease. It is a severe situation able of producing cardiovascular events even at pediatric age. So it's important detecting these patients and treating them as soon as possible. And the problem with treatment is that because they cannot produce LDL receptors properly, we have to use therapies that act independently of the LDL receptor pathway. One of them is lomitapide. Lomitapide is a small molecule that blocks the MTP. MTP is the protein that puts together lipids and ApoB100 in the liver producing VLDL, or ApoB48 plus lipids in the intestine producing chylomicrons. The drug has been approved already for the use in adults with homozygous FH by the FDA and EMA. And the only idea of its action on pediatric population was a publication that we did several years ago, collecting 11 patients that were treated with lomitapide. And we already observed this was a real world observation. And we see that it was a mean reduction in LDL cholesterol of about 58%. However, it was necessary to perform proper trial. So we did the lomitapide phase 3 single-arm open-label multi-center study in homozygous FH patients from 5 to 70 years, the APHT 19. Here you have the flow chart of this study. So we screened 49 patients. 46 of them went into the running period. The running period was very important for this drug because in this running period we put patients in a very low-fat diet plus supplements of vitamins, of liposoluble vitamins and essential fatty acids. And we distribute them in 3 different age groups, although the analysis has been done in 2 groups. After that, these patients went to the efficacy phase. The efficacy phase had a duration of 44 weeks. In fact, the data regarding the efficacy phase have been published already in the Lancet DE, and I had the opportunity of presenting them last year in Lyon. But just to remember the main results, so it was observed a reduction of 56% in LDL cholesterol in the young group of patients, and 51 in the other one, an average of 53.9% reduction. And on top of that, 42% of them achieve an LDL below 135 milligrams per deciliter. After this efficacy phase, all these patients went to the open-label safety phase. The safety phase had a duration of 80 weeks, and so now we have experience with the use of lomitapide for 104 weeks. That means 2 years' time. And in this safety phase, our aim was, of course, looking at the impact at the longer time on lipids and medications associated to lipid therapy, but also the issue safety, things like so the TAs, the impact on hepatic and gastrointestinal aspects, growth, maturation, and also impact on fat-soluble vitamins and essential fatty acid. The dropout rate was very low, so the results we have are really robust, I think. So the data that I'll give you, I think, are representative of the effects of this drug in this group of patients. Here you have the impact on the LDL levels. As you see, the maximum reduction was observed at the end of the efficacy phase, that was at 24 weeks. Then when the patients went to the safety phase, the investigators had the opportunity of changing the background lipid-lowering therapy, modifying also the dose of lomitapide. So this second part of the study is more a kind of real-world impact in this population. However, as you can see here, we observed a very steady result in terms of reduction in LDL, with a reduction always between 40 and 50% from the baseline value. On top of that, 53% of the patients achieve LDL below 135 across the study, and at least in one time, 86% of the patients obtain an LDL reduction of more than 50%. Here you have the TAs, and 74% of the patients show any kind of TAs. However, only one had a serious TA associated to the medication. Was a patient that showed an increase in transaminases 5 times above the upper limit normal. And in 2 cases, the adverse events result in discontinuation of therapy. This happens early in the study, was in the efficacy phase, and were 2 brothers that had a moderate kind of diarrhea, but they decide that they don't want to follow the study, and they stop therapy. So in general, the adverse events were mainly gastrointestinal disorders, as you see here, and hepatobiliary disorder. The most frequent hepatic TAs were elevation in transaminases that was observed in 30.2% of these patients. Regarding the content of fat in the liver, we had the information with magnetic resonance imaging in 19 patients at baseline, and then we had a follow-up also by RMI in several patients across the study, as you see here. And as you see, the fat in the liver was increased. But I would like you to notice that the baseline fat in the liver was already 3%. So they do not start from zeros, they start already with some fat. So this 7% that was obtained was just an increase of 1-fold from the basal line. When the drug was stopped or was withdrawn, the fat concentration was reduced. As you see here too, there are 7 subjects that had an increase of transaminases above 3 times the upper limit normal, but this was handled by changing the dose and modifying the prescriptions, and was perfectly accepted clinically by the investigators and patients. Talking about the amount of fat, let me compare the evolution of fat in the liver with the patients in the seminal study by Marina Kuchel in 2013, including 29 adult patients with homozygous FH. As you see, in the basal line, they start with almost zero fat in the liver, while our population start with 3%. So the increase from the baseline in the children was less than that observed in the adult population. So we think that we can handle perfectly the amount of fat that can be accumulated according to the use of this drug. Impact on body mass index, maturation, growth, etc., was negligible. It was a reduction in body mass index according to the Z-score, mainly affecting those patients who had overweight or who were obese. On the other hand, everything was normal, no concern at all in terms of development in this group of children. More than on top of that, so we have measurements of fat-soluble vitamins for these 104 weeks, and as you see here, vitamin A, D were perfectly within the normal ranges or above the normal values, and vitamin E was higher. As you know, vitamin E is transported with LDL. If you have high LDL, you will have high vitamin E. But when, and of course, when we reduce LDL, the vitamin E was reduced, but well within or above normal ranges. Regarding the essential fatty acids, in this case, the N3 fatty acids, you have a normal concentrations of alpha linoleic acid, and also the derivative eicosapentaenoic and docosahexaenoic were within the normal ranges. And regarding the N6 fatty acids, so the amount of linoleic and also its derivative arachidonic acid was also normal. So I think that we have clearly demonstrated that lomitapide produces a clinical meaningful LDL reduction in patients with homozygous FH. We have an observation of 104 weeks, 2 years of lomitapide. Lomitapide is generally well tolerated. You need to fight for the tolerance. You have to control and modify therapy in some of the patients, but in general is well tolerated. And there are no new safety signals identified, and the safety profile was comparable to that observed in adults, supporting a favorable benefit-risk ratio for the pediatric use of lomitapide. I think we have data robust enough to say that lomitapide is now ready to be used in the pediatric population with homozygous FH, and we will open a new hub for this population, and we will change the paradigm of the disease. Thank you very much for your presentation.
Thank you for a wonderful talk and very nice data. I think we need to move on because of time. Can we move on to the next speaker, please? We have Dr. Stella Covino, who is from Sapienza University of Rome, and she's going to present to us on the talk, which is entitled Functional Characterization of Variants of Uncertain Significance in Patients with Heterozygous Familial Hypercholesterolemia using a flow cytometry assay. Dr. Covino.
Good afternoon to everyone, and thank you for the opportunity to present this data. I have nothing to disclose. Familial hypercholesterolemia is a common genetic disorder of lipid metabolism with an heterozygous frequency of 1 out of 250 in the general population. It is clinically characterized by high LDL cholesterol levels in the blood and increased cardiovascular risk. Clinical diagnosis is based on Dutch Lipid Clinic Network score criteria, while the genetic diagnosis is made by finding a causative variant in one of the 3 FH genes, LDLR, ApoB, or PCSK9, with the most of the cases traced to LDLR. With the use of next-generation sequencing techniques, the number of variants identified in FH genes has increased significantly, and the interpretation of the variant's pathogenicity became the most challenge in the molecular diagnosis. For this reason, in 2015, the American College of Medical Genetics and Genomics released guidelines for the annotation of variants. These guidelines were subsequently modified by ClinGen expert group, but despite the use of these guidelines, around 40% of LDLR variants are now classified as uncertain. And less than 15% of all LDLR variants actually reported in the ClinVar database are proven to affect LDLR function by functional study. Variants classified as uncertain are a problem because they cannot be used for the clinical decision-making. They preclude cascade screening in the patient's family, and sometimes they preclude access to new lipid-lowering therapies. The aims of this project were to assess the functional impact of VAS in the entire LDLR cycle using a flow cytometry technique, and to evaluate any possible association between variants defined effective after functional study with FH phenotypes. Moving on methods, regarding the flow cytometry approach, we selected 19 unique VOAS in 33 patients enrolled in the Italian LipidGen study in our lipid clinic, and PBNC of these patients were isolated from blood sample and stimulated in a medium containing the lipidated serum with Dynabits anti-CD3, anti-CD28. To evaluate the binding and the uptake of LDL particles, we used body PLDL, while to select the population for the analysis, we used 3 different antibodies, CD4, LDLR, and 4-1BB. As control set, we used 3 heterozygous FH patients carrying a non-variant previously tested by functional study as positive control, and 3 normolipidemic and non-mutated sample as negative control. Each test were repeated 3 times, and the cutoff we used to define normal or abnormal activity was given by ClinGen FH expert panel LDLR guidelines. To confirm the flow cytometry data, we employed a microscopy-based approach in which PBNC were stimulated in the same way, but we used LDL labeled with OIO red O to evaluate the binding and the uptake of LDL particles, and we used formaldehyde to distinguish between LDL on surface from internalized LDL under the microscope. As control set, we always used a positive and a negative control. Here you can see the list of all variants selected for the study, the number of patients enrolled for each variant, and their clinical data, like untreated LDL cholesterol levels and Dutch lipid clinic network score at the LipidGen enrollment. Variants highlighted in red are those for which it was possible to conduct a cascade screening. Moving on results, we evaluated the entire LDLR cycle in the expression, binding, and uptake activity. Regarding the expression, 9 variants were defective compared to the cutoff we used. 7 variants were defective in the binding of LDL particles, and 8 variants were defective in the uptake of LDL particles. As summarized in this table, some variants showed more than 1 defect, and in particular 3 variants highlighted in red showed all 3 defects, for a total of 14 variants that were defined as defective. Regarding the microscopy-based approach, due to a lack of time, I reported only the 3 variants that showed all 3 defects, but we can see that with microscopy approach, results were similar. Regarding the second aims of this project, the possible association between variants defined effective after functional study and FH phenotypes, we can see that 28 patients had at least one defect in the LDLR cycle, and in the panel B, we can see that their untreated LDL cholesterol levels were slightly higher than patients without defect. And moreover, we can see that these levels were similar to patients we used as positive control. Looking at the distribution of the DLCN score in this group of patients in the panel C, we can see that 92% had a DLCN score equal or higher to 6 at the Lipigen enrollment. In conclusion, 14 variants showed at least one defect in expression, binding, or uptake activity, and appeared to be associated with higher untreated LDL cholesterol levels. 7 of these variants were reannotated as pathogenic after functional study, and a total of 20 patients with uncertain diagnosis in our lipid clinic received a positive FH diagnosis after this study. Based on these results, the ex vivo assessment of LDLR function may be of great value in solving the clinical problem of VUS in FH. Thank you for your attention, and thanks to all the participants in this study.
Thank you so much. Due to time constraints, unfortunately, we do not have time for questions. So we go to the last presentation.
Thank you.
And the last presentation is bempedoic acid and limb outcomes in statin-intolerant patients with peripheral artery disease. And it will be presented by Mario Enrico Conanico. Yeah, that's the same name. I just saw something. From Aurora, USA.
Thank you so much, and thanks for coming. So essentially, I will go through the presentation on the CLEAR Outcome trial, and I'm very grateful to have this opportunity to present on behalf of the investigators. I'm part of the faculty at CPC Clinical Research, University of Colorado in Denver. So, as we know, also from these 2-3 days of Congress, we see an untreatment of patients in terms of LDL cholesterol. And that's particularly true in patients of PAD. And essentially, more than 2/3 patients are outside the range for the treatment in patients with PAD. But we know from the Optimised trial on your right that, the combination therapy, the early combination therapy, including statin and ezetimibe, can reach the goal for LDL in a faster way and also in a meaningful way in patients with PAD. The CLEAR Outcomes trial is very well known, of course, where bempedoic acid was compared with placebo in statin intolerance patients and was able to decrease of 13% the occurrence of 4-point MACE. And essentially, also, there was a sustainable reduction in the LDL cholesterol, and essentially also for the safety profile, there were no concern, actually, from the trials. So that's why, in patients with statin intolerance is now represent one of the key players in lipid-lowering space. And so essentially, we did this analysis just to remind you the trial cohort essentially was split between 2 groups. One of was the primary prevention group and the secondary prevention group. And we defined PAD, including those with symptomatic claudication, of course, with either ABI less than 0.9 as usual, or previous revascularization of lower extremity or amputation as well. And the aim was to assess, in the postdoc analysis, whether the bempedoic acid is able to decrease the occurrence of major adverse limb outcomes in patients with or without PAD. And for male, we defined the composite outcome of worsening PAD, including also worsening claudication, as well as CLTI and ALI. And we assessed also 4-point MACE and 3-point MACE according to the main trial of CLEAR Outcomes. As you can see, so we have a good representation of patients with PAD, was about 12% of the overall cohort, and essentially was very well balanced also for the cholesterol at baseline, and essentially the use of the other lipid-lowering therapy was very low, including up to 20% for statin and less than 1% of patients with PCSK9 inhibitors. And, about 12% of patients with ezetimibe. But who are these patients? Essentially, if you see on the left side, essentially patients without PAD essentially have CAD, of course, and also prior ACVD event. But the proportion of 12% of patients on your right, to patients with PAD, just 30% had history of polyvascular disease, mainly coronary artery disease, and up to 9% patients with cerebrovascular disease. And essentially, the event distribution was mainly proportional in patients with PAD, of course, as expected. There were also a good proportion of events in patients without history of PAD at baseline. So, PAD events, including male, can also happen in patients without history of PAD. So that's why it's important, the awareness of the disease. And essentially, most of the PAD events were worsening PAD, leading to revascularization. But also we have an important proportion, 21%, between CLTI and ALI, so also patients with kind of events with an important impact on the prognosis. So in patients with PAD, we have the analysis rate of first male of 2.6% overall. When we compare with bempedoic acid, we saw a relative risk reduction of 36% of male in patients with PAD. This is for the first male, comparing bempedoic acid versus placebo, with 2.5% of absolute risk reduction. If you want to see total male, we see on the left side the whole cohort, and was able to decrease of 27% in the whole cohort of patients, the occurrence of total male. But if we want to split on the right side in patients with and without PAD, we see that, of course, the magnitude of the effects were particularly true in patients with PAD, with a reduction of total male of 45%, so very important. And in patients without PAD, we saw also signals of the reduction in male. And that's the forest plot. As you can see, the outcome, including also the composite outcome, was consistent. There was a consistent reduction by bempedoic acid, regardless, of course, the outcome, but in particular for male in patients with PAD. And I want to show you also the other outcomes, including also 3-point MACE, so which means CV death, non-fatal MI, non-fatal stroke, and male. And also in patients with PAD, we saw on the left side a significant reduction, and also in this other composite outcome of 35%, while in patients without history of PAD of 14%. So also we're very consistent in patients also without PAD. And this is just the bar graphs of patients, including also the outcome for 4-point MACE or male, so a composite outcome on your left, and of a 3-point MACE or male on your right. As you can see, consistent, so regardless the background of PAD history, essentially we saw a significant reduction in the occurrence of the ischemic events by bempedoic acid, particularly true in patients with PAD given the high risk at baseline. So that's why it's very important to be aggressive in the treatment in patients, in particular with the history of PAD. So a couple of slides to conclude and maybe to discuss if we have time. We saw that a significant number of male events occurred also in patients without PAD at baseline. So that's very important for the awareness of the disease. And then also, the male events was in patients with PAD in the placebo group, 2.6% per year for the first, and then also for MACE, 4.4% per year, which is an important number. And then if we consider the total events, including 4-point MACE and male, we have more than 10 events per 100 patients per year, which is a very important number. So that's why this kind of population is very high risk for multiple events during the follow-up. Bempedoic acid was able to decrease the first occurrence of male of 36% and 45% when you consider total male, which is a very important results. And then also, if we consider 3-point MACE and 4-point MACE plus male, we had a relative risk reduction of 29 and 35%, which is also very important in terms of outcomes, in long-term outcomes in patients with PAD. So important here to see that also in patients without PAD, apparently, we have male events. So that's why, I think it's important also to raise the awareness of the disease also at baseline in patients that are including in trial for other reasons. And then also one of the key is to lower the LDL in patient with PAD and also without. It's one of the risk modifier in patient regardless the history of PAD. And that's another demonstration that the early combination therapy, including also bempedoic acid, lower the risk of MACE and MALE, regardless the background of PAD, but in particular for those with PAD at baseline. Thank you.
So why do you think that bempedoic acid had more effects in patients with PAD?
Essentially, the main reason is that they have an higher risk at baseline. So the magnitude of the reduction is particularly noted in patients with polyvascular disease, including also PAD. So that's why, also in patients with PAD, a stepwise, so an early combination of dual therapy, I think is now warranted. I think is now needed, given the high risk at baseline. This patient in the placebo arm have 10 events per 100 patients per year. That's a very important number. So I think it works, so regardless the PAD background, of course, but in particular for PAD, given the high risk at baseline. So the magnitude is bigger, of course, if we compare with patients without PAD.
Okay, thank you. I think in the sake of time, we have to conclude this session. But first, I would like to thank all the speakers and also the audience live and also the audience online. And with that, I wish you a very good evening.